This is a case of a 64-year-old lady who has dyspnea on exertion for the last 2 years. Most recently, her symptoms became more prominent at rest, and so she decided to seek some medical attention. Now, she did go see her primary care physician, and she was found on physical examination to have decreased breath sounds, predominantly in the bases in the right lung. She isn't exactly a great performance status, perhaps ECOG PS1. In her past medical history, she just has some mild hypertension on lisinopril, but other than that, she's not really on any other medications. Now, she does have a 15-pack-year smoking history and is trying to quit. Her CT scan shows 2 masses in the right upper lobe and several masses in the liver. On her biopsy of the right lung mass, it looks like she has an adenocarcinoma. There is a mutation profile that is run. She is EGFR negative as well as ALK IHC negative. She's also ROS1 negative, and she's also KRAS negative. But when her PD-L1 is done, she's 56% for the IHC. Now, her PET-CT also demonstrated the lung masses in the right upper lobe as well as multiple masses in the liver. And the brain MRI is negative for any metastatic disease. So she is a stage 4 adenocarcinoma of the lung, and she's initiated on carboplatin pemetrexed and pembrolizumab. So this is a pretty typical case of what walks in your door for a new diagnosis of metastatic adenocarcinoma of the lung. In our lung cancer patients, we always get a smoking history because it is quite relevant. Nowadays, with the immunotherapies, we do know that current smokers, former smokers actually have a good response to these immunotherapies, and it may have something to do with tumor mutation burden. But there's a lot of hypotheses as to why that might be. It would also be very relevant if she were a never smoker or minimal former smoker, because we know that those patients can carry oncogenic driver mutations, which would be very useful in understanding what to give optimal therapy for. In patients with stage 4 adenocarcinoma of the lung, we typically recommend, now there's several options. So in the past, we used to recommend a platinum doublet with and without bevacizumab if they were eligible for bevacizumab. Now we have several options. In the case of metastatic adenocarcinoma, we have this triplet regimen, carboplatin, pemetrexed, and pembrolizumab, followed by pemetrexed, pembrolizumab maintenance therapy. Now, this is a new regimen. It was recently published in the NEJM Keynote 189, and it actually shows significant survival benefit over a platinum doublet. For patients who don't have an oncogenic driver mutation, the prognosis is still grim. This is still a terminal disease, and so we clearly do need better therapies. We definitely have some advances with the immunotherapies, but this doesn't seem to benefit all of our patients yet. So there still certainly is a knowledge gap, and we have to continue to do clinical trials to prolong life for our patients.